Anyone who has experienced a sudden, blinding spike of head pain knows the immediate terror that follows. In that moment, your mind rushes to the worst-case scenarios, a growing brain tumor or a ruptured aneurysm. The natural reaction is to want absolute certainty. You expect to be rushed to a hospital and slid straight into an MRI machine to rule out a deadly condition. But in the clinical reality, a doctor usually skips the scanner entirely. Instead, they sit down and ask you a long, highly specific list of questions about your symptoms and medical history. This can feel dismissive to a patient in agony. Yet this question-based evaluation is actually a highly calibrated, evidence-based diagnostic algorithm designed to properly triage your pain. To understand why doctors rely on these questions, you have to look at how medicine divides head pain into two distinct categories, primary and secondary. This chart breaks down the prevalence of these two types. The massive section here represents primary headaches. In these cases, the headache itself is the disease. Think migraines or tension headaches, which account for over 90% of all cases. The remaining fraction are secondary headaches. Here, the pain is merely a symptom, a biological alarm bell warning you of underlying structural damage, a brain bleed, or an infection. A physician's main objective during your exam isn't necessarily to confirm a migraine. Their job is to actively hunt for that dangerous sub-10% sliver of secondary headaches. And to find those hidden dangers, doctors don't use default imaging. They listen for specific clinical warning signs called red flags. These warning signs dictate exactly when medical imaging is required. At the top tier are the emergency red flags, demanding an immediate trip to the ER. The most urgent is the thunderclap headache. This is strictly defined as severe head pain that reaches its maximum explosive intensity in under 1 minute. That specific speed of onset is a critical diagnostic marker. It is highly indicative of a subarachnoid hemorrhage, often caused by a ruptured aneurysm. Next are the neurological red flags. If a headache is accompanied by sudden physical weakness on one side, sudden vision loss, or an altered mental state, the brain's physical structure is likely compromised. Then there are the infectious red flags. A severe headache paired with a fever and a stiff neck points directly to meningitis or encephalitis. Only when a patient presents with these specific emergency features do doctors bypass the observation phase and mandate immediate CT scans or spinal fluid analysis. Transitioning to the ambulatory red flags, these are subtle indicators suggesting a serious condition that requires prompt testing, even if it isn't an immediate emergency. Take the positional shift. This refers to headaches that exclusively occur or get noticeably worse when you assume an upright standing posture. This gravity-dependent trigger is a primary indicator of intracranial hypotension, which is often caused by a cerebrospinal fluid leak in the spine. Age is another critical factor. Entirely new headache patterns that start after age 50 carry a significantly higher risk for structural problems, like late-onset tumors or inflammatory conditions like giant cell arteritis. Even in younger patients, a sudden pattern change requires investigation. If someone with a lifelong history of throbbing migraines suddenly develops a featureless, continuous daily pain, the underlying cause has likely changed. These specific details from your medical history, rather than the sheer intensity of the pain, dictate exactly when a patient truly needs an MRI. This raises a paradox. If secondary headaches can be fatal, why don't doctors just scan every single headache patient to be absolutely safe? The answer lies in a major medical risk associated with high-resolution imaging, known as incidental findings. Looking at this array of brain scans, 2% of MRI examinations reveal major intracranial abnormalities that are entirely harmless. Discovering these benign anomalies doesn't help the patient. Instead, it triggers massive psychological anxiety, leads to invasive biopsies, and traps them in endless follow-up scans. Ordering an MRI without a strict algorithmic red flag often causes far more harm than good. For the vast majority of patients, the reality is straightforward. If you clear the red flag checklist, your headache is primary. Yet, primary headaches are surrounded by persistent medical myths. Many patients assume routine high blood pressure causes their chronic headaches. Clinical data shows that unless you are in a severe hypertensive crisis, high blood pressure rarely causes head pain. Then there is the sinus headache. This data visual tracks self-diagnosed sinus headaches, revealing 88% are actually misdiagnosed migraines. Migraines frequently cause nasal congestion and facial pressure. Because symptoms overlap, both patients and doctors easily misattribute the pain to sinus pathology. Holding on to these false alarms actively prevents patients from accessing the targeted primary treatments they actually need to feel better. A successful medical diagnosis for a severe headache doesn't always end with a machine. A doctor taking a thorough history, checking your reflexes, and looking into your eyes is a highly sensitive diagnostic test on its own. Leaving the office without a referral for a CT scan is clinical proof that you successfully cleared the red flag triage. Understanding this diagnostic algorithm empowers you to communicate your symptoms accurately. It helps you avoid unnecessary radiation, skip the anxiety of incidental findings, and focus directly on treating the true source of your pain.